Hello, good evening, everyone. Okay, welcome all of you, and let's us continue to share the link and invite others. The time is around. I see Angel, Lavender, Ibra, Joshua, welcome. Mr. Moses, welcome. Christina, John, Oscar, I see you there. All you are welcome.
Thank you
First of
very much.
all, I wish you all Happy New Year 2025. Uh, this is the last session of critical care to open this new year 2025. That is a great blessing. So let's continue inviting others because the time is up. We've already shared the timetable through our forum. So let's share the link and remind others that time is up. Join and listen up the presentation. Our today's session from critical care area, advanced strategies in monitoring critical ill patient in healthcare or in intensive care unit or ICU are very important because they provide critical care and life support for patients who are seriously ill or injured. Also, the team of specialists continuously monitor the patient condition, apply life support techniques in some circumstances, and they are also apply advanced care technique to help the patient. Example, respiratory, cardiovascular support. Or through this intervention, there will be an improved survival of patient. And we should remember that the gift of a human is life. So surviving, growth, and explore the environment is a great achievement. So I want to remind you some important tips that to follow during this online presentation. First issue is how to use the icon that are below your screen there. The first icon is video from the left side. So if you want you to see wherever you are joining us, example Malaba, I see you Malaba there because you have clicked the first icon. The second icon is mic. So we allow the person who is presenting or anyone who will be allowed to contribute or ask a question to unmute the mic. So others, we should mute the mic to prevent noise during presentation. So the third icon at the bottom of your screen is the hand. So whenever you have a question, contribution, so you press that icon and the team will see you and allow you to ask something. So as you see, I've raised the hand and so we'll be using that icon during discussion time. And the fourth icon is three dots. So when you press three dots, the pop-up menu open up. There are several features. The first two features are very important. The first one is in call message, so you can pose your question or you can write something or contribution, or you can write your number if you are not in our forum. The second icon is the share screen. So only one is allowed to share the screen for presentation. If anyone will share the screen, it will interfere with the presentation. So do not share the screen. And the last icon is the red button. So when you want to left the meeting, you press that icon. After saying that, I'm still reminding you to share the link and reminding others to join because the time is up. I want to know if Mr. President Moses Yavalisto, are you hearing
Yes,
me?
I'm here. Good
Okay,
evening.
good evening. Welcome, Mr. President of
Thank you
Mofate.
very much. I'm very
Yes,
happy to be here together with you.
thank
So,
you.
as I've tried my level best to show up the screen that indicates the timetable of today. And the first area, I think the conference manager, Mr. Joachim Kilas, has already chipping on. We have the joining and welcome, all of us. Probably we have the new one that today are joining today at the first time. So we would like to take a chance to welcome all of them. In the second portion that we are going to do ourselves, based on the timetable, is the opening remarks and introductions that I'll be going to do it. But almost we will continue with the content presentations that will be carried by somebody, Malcolm James, as we have shared by the timetable. But almost even we have we have another activity like ECG presentation that will be carried on with Mr. Joshua Duma, although the content are the same. So these two persons, they are working together and they are having this content preparing together. So they will have clear discussions, all of us. They'll be chipping each other. They'll be separating based on the slides. So the other area that is more much interesting is for discussions, where all of us, we are going to engage enough in discussions. We know that today we will have students who are joining today with us. So probably it will be a good forum for us today to have a different sharing, and also from the other specialists in this area. We know that critical care is like, now we can say like a backbone of our profession. This is one of the very interesting, very important area that we can't escape in any means. So we'll continue scheduling these sessions, but today we start with this one, patient monitoring. Yes, and the final, we are going to close and have some announcement from Mofate. So thank you very much. I think I'll take this chance to continue welcoming conference manager to continue inviting people until the time of introduction. Thank you.
Okay, thank you very much. The timetable is clear, and presenter, moderator, I hope are joining our session. And if they hear me, I want to know the presence of Marco James. If you are there, please, can you greet us? Also the presence of Joshua Duma. If you are
Yes,
there.
I'm here.
Okay, welcome, senior.
Marco James, I'm here.
Okay, Joshua Duma. Yes, I see Joshua Duma. Welcome, senior. Also, our moderator from Kenya, Madam Faith, if you are hearing me, please, can you greet us?
Good evening.
Good evening, madam. How are you?
Fine, thank you.
Yes, welcome, madam. We are pleasure to have you here in this online conference. Welcome, madam.
Okay, so Mr. Kilas.
Yes.
Just we have 2 minutes to go to start our session. So we would like to take a chance also to continue inviting others and also keeping pushing, inviting others, but just by sharing the link so that people they can join to start our session. So like 1 minute left, we are going to start.
Yes, let us continue sharing the link. Also, be prepared, have a notebook and pen to jot down important notes so they can help us during care. So share the link with your fellows so they can join. We have 1 minute left. Also,
okay.
Senior, Mr. President, you have something to say? Yes, welcome.
No, I think it is like 7:10, so we can start our day. And I'll be taking you through the first part of opening and also giving up the introductions of whom we are going together with us today. So, okay, thank you very much. So good evening, all of us again. Yeah, so it is with great pleasure and honor that we welcome you all to this critical care online sessions organized by Mobile Facilitation Team Mofate. So today's we come together as multidisciplinary community of healthcare providers, including nurses, midwives, and medical doctors who have already did the registration. So from various regions within and beyond our borders, including our esteemed friends from Kenya, including Madam Faith, you are most welcome. So these sessions focuses on monitoring a patient in a critical care unit, but there are other areas where there is concern of critical care management. So this topic that lies at the heart of our profession, as I said before, so missions to provide quality patient-centered care. So as we dive into this important subject, we aim to strengthen our collective skills and knowledge, enhancing our ability to deliver the best possible outcomes for patients in need of critical care services. That's why we are here together today, so that we can have advanced discussions with our fellow specialists that have been keeping up the efforts to support us in terms of moving towards the better evaluations of the health caring activities. So for those who have registered continuing professional development CPD points will be awarded, as we have said, through our posters. So ensuring your participation contributes not only to your professional growth, but also to fulfilling the CPD requirements. As we know, if we want to renew the license, we should have a clear CPD points. So as Mofate, we take this guarantee to say that all the sessions that will be facilitating will be providing CPD points based on the CPD point coordinators available at our respective area. But what you have to do in our sessions, just to do the registration so that the attendance will be shared by them. So I encourage everyone to handle the attendance matters with the CPD coordinators at your respective workplaces to ensure proper accreditations of the CPDs as you have attended the session. So the attendance will be shared through the email, the registered email. So additional, the sessions, presentations, materials, notes will be shared through our website. And after sharing through the website, a download link will be sent to your registered email addresses for easy access and download them. So I believe this will further aid you learning and implementation of the concept discussed as we are going to start soon from here. So as president of Mofate, I take this opportunity to thank you for dedicating your time to this session, your commitment to advancing your skills and continuing contributing to the improvement of healthcare services through commendable. So let us engage, learn, and collaborate to make meaningful strides in the critical care practices. And final, once again, welcome these transformative sessions. I wish all the fruitful and engagement learning experience. Thank you very much.
Thank you very much for opening remark.
Okay, so can I continue with the introductions because of time?
Yes, I want, if Madam Faith is there, just to introduce herself and continue with moderating the session and welcoming the presenters. Madam Faith?
Okay, so before that, I would like to take a chance to introduce the moderator, presenters, and the keynote speakers who will be together this time. So as I said earlier, we'll have Madam Faith Sila who will be moderated. So Madam Faith is a clinical nurse education manager at Moi Teaching Referral Hospitals in Kenya with expertise in critical care and emergency nursing. So she's holding a Master of Science in Nursing, Critical Care and Emergency from the Alexandria University, and she combines a clinical excellence with the leadership in education and management. So since 2019, Faith has spearheaded clinical education programs and played a pivotal role in the COVID-19 hospital task force there in Kenya. Also a part-time lecturer and researcher. Her work focuses on sepsis care and antimicrobial stewardship. She is dedicated to advancing nursing education, fostering innovations, and addressing healthcare challenges through evidence-based practice and policy advocacy. So, Madam Faith, if you are here, just raise up your hand and just greet us.
Thank you for the introduction, Moses.
Okay, thank you very much.
Glad that everyone is here. Thank you.
Thank you very much. You're most welcome. So also we have on the board Mr. Malcolm James. So Malcolm James Bilananie is an advanced nurse practitioner and a critical care and trauma nurse specialist with over 10 years of experience managing critical ill patients. So he is serving as an assistant lecturer at course in Mwanza, Tanzania, and also he is a nurse in charge of the surgical ICU at the Bugando Medical Center. So Malcolm combines his clinical expertise with the education, nursing education, and research. He holds a master's in nursing critical care and trauma from MUHAS, and also is a chairperson of TANA, Tanzania National Nurses Associations at the BMC. So Malco is committed to enhancing critical care capacity, mentoring, like what we are going to aim from him today, mentoring young nurses and advancing evidence-based practice to improve patient outcomes, as he has been traveling to the different ICUs in Tanzania to keep mentoring nurses from various areas. And finally, so Mr. Malcolm James, if you are here, just raise up your hand and greet us.
Yeah, I'm here. Thanks very much for your introduction.
Okay, thank you very much. So the final one, we have Mr. Joshua Duma. So Mr. Joshua Duma is a dedicated cardiovascular nurse specialist at the Bugando Medical Center, Mwanza, Tanzania, renowned for his expertise in critical care and cardiovascular health. So he excels in managing complex cardiac conditions such as arrhythmias, and also heart failure, with a strong focus on accurate diagnosis and timely interventions through advanced cardiac monitoring and ECG. The place and the most important area that this man will be taking us through them. So as both and clinicians in terms of this caring of the cardiac related conditions and educators also, Joshua bridges the gap between theory and practice. So empowering healthcare professionals through mentorship, like what we are going to aim from him today. So committed to advancing cardiac care, he aims to specialize further in advancing interventions, engage in research, and establish a mentorship program to nurture future cardiovascular specialists as one of the forecasting planning. So Mr. Joshua Duma, if you are here, please raise up your hand and just greet us as we start on our session.
Okay, thank you so much for the introduction. I am following keenly.
Thank you so much. So these three figures will now be taking us through the whole sessions of today. So on this chance and on board, I would like to take chance now to welcome Madam Faith Silla as our moderator of today to take us through the sessions. So she will talk anything, but finally she will also invite the Malcolm James to continue with the presentations. Thank you very much. You're most welcome.
Thank you, Moses, and the Mofate family at large. We are so grateful for this opportunity this evening. Thank you, participants from Tanzania and across borders for finding time to join in for this very significant discussion regarding our care of the patients that we take care of and our interest in their quality outcomes. The key thing to note is that a critically ill patient is not only found in the intensive care unit, especially in low middle income countries where the intensive care unit capacity is very limited. We have acutely ill patients that are deteriorating and need critical care services, support of one organ or even more, but do not get that space in the critical care unit or in the intensive care unit. As a result, it is very important for us nurses to be empowered to be able to take care of these acutely ill deteriorating patients that need organ support in one way or the other. And that's why we are having such significant discussions, beginning with how do we monitor? When do we recognize that our patient is deteriorating? When do we intervene or take actions as nurses so that we improve the probability of best outcomes for these patients that we are caring for? And it is an honor to have very honorable members leading us in that discussion, and that is Marco and Duma. Thank you for being there, and thank you participants for being there as well. Kindly let's take notes. Let's note things that we would want to have a further discussion on, questions that we would want to ask, and we'll definitely take those questions at the end of this session. Our key talking points is what monitoring parameters do we take note of as nurses? What key interventions are necessary? We'll dive a little bit deep into ECG monitoring, and we'll also look at issues like arrhythmias. How do we monitor them? How do we manage or escalate care? We'll look at the obvious vital signs that as nurses use to triage and manage patients and intervene and continually use those vital signs, like the level of consciousness, which is something above the vital signs we learned in school, and pain management. These are areas we'll focus on. By the end of this session, we hope to see a very interactive discussion that will build on to our competencies as we take care of the acutely ill patients. So kindly, if you're not speaking, mute your mics and join me. You can use the reaction button at the bottom of your screen, and kindly help me welcome Marco to speak to us about patient monitoring of the critically or acutely ill patients. So kindly you can clap as Marco takes the stage. Marco, kindly unmute and take the stage. We are ready to learn from you. Thank you.
Thank you very much, Faith. I'm so excited to share knowledge and the skills with you guys, and I'm humbled to be with you. Someone to share, yes, now. From the introductory part, go back to the introduction, not the ECG, by the way, the introduction. So you can just share that screen of the monitor itself, basically. So, yes, as we now, as I have been introduced, I thought no need for further more introduction to me, but I warmly welcome you, all of you. This is just a picture of what we are going to discuss today and what we are going to share today. So most of patients deteriorating in our units, in our wards, and then later on they get transferred to the ICU. But the deterioration begins in a serial events, which might have been detected through the accurate monitoring of the patient. So all of these parameters here are things which will be discussed in detail with this under this discussion of today. So next slide. So in Tanzania, the need for critical care service is a pressing issue, as we have been discussed so many times, as the government has tried to push hard to improve the standards. We just see the buildings, infrastructure, equipment, advanced equipment, medical equipment, and other things. However, challenges remain significant on the availability of qualified professionals, as most of our ICU nurses who are taking care of this critically ill patient, they have not good background of the critical care services.
Sorry.
That's okay. Yes. So providing safe and the quality critical care services need a qualified, well knowledgeable and skilled nurses. We all know that we are all qualified, we are well knowledgeable and skilled nurses. But for the case of specialty, especially in the special unit like critical care units, need more knowledge and more skills. So bad luck, most nurses working in ICU, they don't have that good foundation on basic critical care. They're just using their basic knowledge acquired during their educational career. And this has been evidenced during the ICU visiting, as I have been traveling to different ICUs. Almost 20-something ICUs in this country have visited them. So I saw the real situation. Next slide. So physiological parameters which are being monitored in ICU is a central part of critical care. So monitoring patient in ICU, you need accurate monitoring of those physiological parameters. By the way, when you say monitoring of a critically ill patient, what does it mean? Monitoring of a critically ill patient is simply an interpretation of parameters and taking appropriate action timely. So I can just say something here. As you find that in most cases, patients are connected to monitor and are not being under monitoring. You might find some parameters are deranged. Like I can say, you find the patient with the tachycardia, heart rate of 138 up to 140 something. Somebody is chilling, just relaxed, waiting for someone to come and they give directions of what to do. That's not a patient monitoring. That's connecting patient to the monitor. So wherever you see any derangement on those physiological parameters, you have to interpret, find out the meaning of it, and taking action timely. And the action is not just direct intervention by yourself, but even consulting your seniors or consulting your other colleagues who are working with them is a sort of intervention. So wherever we are talking about taking action, direct is not just that you need to intervene, everything comes into your angle. You have even consultation is intervention. So the physiological parameters are at you on the deterioration of the patient. So in the duration of the patient condition, help to assess and the response to treatment. Yes, the next slide. So minor delay may lead to morbidity and mortality. This is really, and from the study done by Van Galen at 2016, he recommended that delayed recognition of patient relation is mostly caused by human-related monitoring failures. So this monitoring failures basically comes to the point where you find most of us, we are failing to interpret the meaning of those vital signs to patient. So in most cases, patients are connected on monitors and not under monitoring, as Ava said. Next slide. So usually, monitoring of the patient in this critical care setting are being done using cardiac monitors for accurateness. So using most monitors need proper skills and the knowledge as well. So these monitors reduce the manual works and they reduce errors. So the parameters that are usually being monitored include all of this, which has been elaborated here: the body temperature, pulse rate, respiratory rate, oxygen saturation, end-tidal carbon dioxide, ECG, level of consciousness, as well as urine output. So this guides the therapeutic intervention. Wherever you monitor it correctly, it guides you on the therapeutic intervention you are doing to the patient. Next time. So what are the advantages of this accurate patient monitoring? So one of the most advantages that it gives you early notification of critical changes to a patient health status via RNAs. Again, it guides you a daily intervention therapy. So you are giving some sort of drug, wherever you are resuscitating the patient, you are giving any kind of medication. How do you know that the medication is working properly? So you will start looking for the any changes, any positive changes to the physiological parameters will give you the clue that the intervention we are doing is doing something better to the patient. So again, accurate monitoring improve patient safety significantly. So patient safety is our goal during the course of care. However, in some cases, patient safety are very compromised due to that insufficient knowledge and the skills of caring a certain condition. Again, it gives useful real-time information of the patient, as you have said. Something to note that careful attention to the trends of these deviations will alert you to early signs of clinical deterioration. As I have said, if you give and do a tracer start, a patient in a normal room, how many of them deteriorate and being transferred to HDU right on to ICU? A lot of them. And wherever you ask what happened, sometimes you find no report, no other information relating to the patient trends of vital signs and whatever the case. So inadequate awareness and the limited knowledge among nurses remained the challenge, as we have said. So if we are keen with this one, thought the patient safety will be protected well. So that's the introductory part of this session today. Now I'm handling this again to Faith, Madam Faith, for welcoming Mr. Joshua Duma for now ECG and the pulse rate session.
Thank you, Marco, for that great introduction part. At this point, we'd like to dip a little bit into the ECG interpretation and a bit of how do we manage the arrhythmias that we see among these critically ill patients. But the most important take-home in this section for all of us as nurses is first, let's be able to recognize that is not a normal ECG tracing. It begins with the cognition so that we escalate care as soon as possible. Welcome, Duma, and take us through the electrocardiogram. Thank you.
Okay, thank you so much for the good introduction from Mr. Marco James. As he has said before, that critical ill monitoring is diverse. Okay, so its diversity also includes electrocardiogram monitoring. So first of all, I want to talk about the importance of electrocardiogram monitoring in ICU. So why is ECG knowledge is crucial in the ICU? We have several reasons why is ECG important. Why do nurses need this basic ECG knowledge in caring for a critically ill patient? So as Madam Faith told us before, that critically ill patients are not only in the ICU. We can get even critical ill patients in normal wards or elsewhere. So whenever the critical ill patient or whenever a patient is being monitored, one of the good and important parameter is ECG. So why is ECG important? First of all, ECG helps us in continuous monitoring. So what do we monitor in ECG? So continuous monitoring and observation of heart rhythms. Once a patient is being connected to a monitor, we do monitor heart rhythms. We monitor the electrical conduction of the heart. How is it going? So we do monitor the arrhythmias. Through ECG, we can detect different types of arrhythmias, such as atrial fibrillation, ventricular fibrillation, bradycardia, tachycardia, and other types of arrhythmias. The other reason why is ECG important is to detect these arrhythmias early. Once a patient is being in monitor, it's very easy to detect the arrhythmia, the rhythm derangement early. Once a patient is in arrhythmias, it's very important to detect it early, and the only means or the only way to detect these arrhythmias is through the cardiac monitor. So the other reason why is ECG important, it helps us to assess the cardiac functioning. Okay, cardiac functioning in which way? So sometimes through ECG we can detect the ischemia. Once a patient is in ischemia, through ECG can help to detect the signs of ischemia early. So it can be ischemia or infarctions through the rhythm changes. It can also help to evaluate the treatment response. Once the patient is in different kinds of drugs, let's say for example, a patient is in inotropes, the patient in electrolytes replacement, it's easy to detect the treatment response through ECG. Also, through ECG, you can detect or we can predict the hemodynamic stability. Through ECG, the changes of heart rate can be early indicator of hemodynamic stability. So monitoring the trends through ECG can help to predict and prevent the potential deterioration. Okay, then finally, I can say that why do ECG important? The other important part of ECG in monitoring for the critically ill patient is it can guide you through clinical decisions. And the clinical decisions, what does it mean? Mr. James told us about the monitoring. Once it's quite different when saying that the patient is in the monitor and monitoring the patient who is connected in a monitor. So how can ECG help us in guiding through clinical decisions? So it's all about real-time findings. Through ECG, you can get a real-time findings. So once the patient is in arrhythmia, once the patient is in bradycardia or tachycardia, it's easy to detect early through a monitor. So every nurse should be aware and knowledgeable a little bit about these arrhythmias. So once the patient has changed his or her condition, every nurse through ECG can be able to detect and take a real-time action and do a quick intervention. So by explaining shortly about the importance of ECG, yes, I can go through, yes, okay. So as I've said, ECG, first of all, is a non-invasive procedure. It's a non-invasive procedure. So through ECG, you go previous slide, okay. As I've said that ECG detects the electrical activity of the heart. So the electrical activity of the heart, it tells different things. One of it, the electrical part of that tells about the cardiac cycle, how the heart beats, how the heart pumps, and how the body is perfused. So it's very important to understand the hemodynamics through ECG. So in ECG, you go maybe the next slide. Okay. In monitoring for critically ill patient through ECG, we first place the electrodes. The red dotted parts are the electrodes. So ECG is like cameras. It pictures the heart through different angles. So through picturing the heart in different angles, it's very easy to detect what is wrong in a certain part or in a particular part of the heart. So these electrodes can picture the heart in the anterior part, in the lateral part, posterior part, and inferior part. So through ECG rhythms, you can know and you can understand which exactly part of the heart may be suffering. For example, in identifying ischemia or infarction, through ECG, it's very easy to detect which part of the heart is suffering from an ischemia. whether it's anterior part, inferior, or lateral, or posterior part. So the red dotted parts are the electrodes. They are like the cameras placed in different angles of the body. Picture the heart through its different angles. Next. Okay. So as I've said, okay. So this is an example of 12 lead ECG. 12 lead ECG is the kind of picturing of the heart which shows almost all parts of the heart. So as I've said, through ECG we can review and we can see different parts of the heart. So if you have that ECG strip, the 12 ECG strip, it can show you different parts of the heart and which exactly part is suffering from either ischemia or infarction and others. So we usually have different leads. So we can't talk deeply about the science of it, but in a nutshell, as an introduction, as a basic, we all should know that we have different parts of leads, different parts of cameras which pictures the heart in different angles. So these 12 leads is made up by different kinds of leads. We have bipolar leads, unipolar leads, etc. But knowing exactly different parts of the heart is through these different leads. So we have the leads which picture the inferior part of the heart. These are the lead 2, lead 3, and AVF. So through this picture, you can see we have lead 2, we have lead 3, and AVF. So these are the leads which can show you the inferior part of the heart. So once the inferior part of the heart is suffering from ischemia infarction, it's you can only detect it through these lead 2, lead 3, and AVF. We also have the anterior part. The anterior part can be detected through these V3, the precordial. They are called the precordial leads. Precordial leads are the leads which are placed in the anterior part of the chest. So they picture the lead 3 and the V3 and V4 picture the anterior wall of the heart, and we have the leads which picture the septum of the heart, the wall that separates 4 different chambers. We have V1 and V2. We also have lateral leads. Lateral leads are the leads which picture the lateral part of the heart. We have lead 1, we have AVL, we have V5 and V6. So whenever it's happening in the lateral part of the heart, can be seen through lead 1, AVL, V5, and V6. We also have the anterior wall or anterior part of the heart. This can be easily seen through V1 to V4. So in shortly, once you have the ECG strip, the 12 lead ECG strip, one of the most important things, you should be able to identify which exactly part of the heart is suffering. Next. So this is an example of 12 lead ECG. So you can see different types of leads: lead 1, lead 2, lead 3, V1 to V6, AVL, AVF. As I've said before, this can help this can help you to focus which part of the heart is exactly suffering. Next. So talking about arrhythmias. So arrhythmia is any abnormal heart rhythms or abnormal heart rate. So any rhythm which is either above normal range or below normal range can be termed as an arrhythmia. So we have different types of arrhythmia. One of it is bradycardia. What is bradycardia? Bradycardia is just in adult, specifically in adult, any heart rate before 60, because the normal heart rate is between 60 and 100. So any heart rate between 60 can be termed as bradycardia. So through ECG, it's very easy to see bradycardia. So once the heart rate is below 60, the ECG can show you. ECG, as the first slide tells that the heart rate is automatically calculated by the machine itself. So you can observe the heart rates through the monitor, and whenever the heart rate is below 60, it's an alert that this patient is running bradycardic. So you need to get aware and get alert that you need to take action. So once you have this idea of ECG and management, it's quite easy to take action as a nurse, specifically in a critical ill setting. So, but for assessment and management of a patient with symptomatic bradycardia, so in a ICU specifically, or in a critical ill patients, bradycardia should be associated with symptoms, because generally there are some people who can have the heart rate of below 60 and it's just a normal rhythm. For example, for the it's a normal heart rates. For example, for the athletes, okay, athletes have different kinds of maneuvers and mechanisms. The Valsalva maneuver is called, that they can be having the heart rate below 60 and can be a normal heart rate. So once you say that the patient is bradycardic, then it should be symptomatic. It should be showing the signs of bradycardia. And clinically, the bradycardia can be, if it's associated with symptoms, it has to be less than 50. Next slide. So in a critical ill setting, in order to say that this patient is bradycardic, then it has to be a slow heart rate, as I've said, below 60, or sometimes below 50, with association of symptoms. The symptoms that can be associated with bradycardia can be altered mental status, chest discomfort, signs of shock like low blood pressure, etc. Next slide. Okay, this is an example of 12-lead ECG showing bradycardia. So bradycardia, we are much concerned about the heart rate, as I've said. So there is the way that you can count heart rates through this ECG. I can't go deep about it, but sometimes we can count. We have to see if the rate is either regular or irregular. We have the different. We have in ECG we have different waves. We have P waves, we have QRST waves, and we have T waves. So counting for bradycardia or counting for the slow heart rate, we have different ways of counting the heart rate through 12-lead ECG. We'll see it later. Next. Okay, this is also one of the example of bradycardia. One of the conditions that can be associated with bradycardia is atrioventricular block. One of the conduction, it's called conduction block. Once the heart is having conduction defect, one of the transmitting bundles is blocked. One of the signs you can see is bradycardia, the slow heart rate. So this ECG strip here is an example of the ECG strip which shows bradycardia, the slow heart rate. We'll talk it deeply next. So once you have an ECG, once you have a cardiac monitor in ICU, what can specifically show that the patient is in bradycardia? So one of it is, as I've said, the slow heart rate. As you can see, this monitor shows the heart rate below 50. The hypotension, as you can see, the pressure is almost below normal. So these are the signs that can show that the patient is running bradycardic through monitor. Slow heart rate below 50. So we are not just assessing monitor. That's maybe let me emphasize the most important point. We do not monitor the monitor itself. We monitor the patient. So once the patient is displaying deranged parameters, first of all, you need to assess the patient. Is he or she showing the signs of slow heart rates? Is he or she showing the signs of low blood pressure? You need to assess for the hemodynamics status presentations. Is the patient showing the signs of poor cardiac output? Because once the patient is having slow heart rates, low blood pressure, can present with the signs of poor cardiac output, like cold extremities, altered mental status, etc. So once you see the parameter like this, do not quickly go to an intervention. You need to assess the patient. Is the patient presenting the features that are seen in the monitor? So do not run into an intervention. Assess the patient, then go carry on. Next. So once you find that the patient is bradycardic, the First important thing, you need to maintain an airway. As the primary survey for the critically ill patient, we start with ABC. So we need to assess the airway. Once the patient is having low blood pressure, low heart rate, one of the compromises that we get from the patient is difficulty in breathing, poor lung perfusion. The patient could be having the poor perfusion, specifically in the lungs, in the brain, etc. So the first intervention, you need to maintain patent airway so that the patient can be getting okay, sorry. So you need to maintain patent airway, the first thing. Then the other thing, you need to oxygenate the patient. You give oxygen. The other thing, you need to yes. Anyway, we can assume that the patient is connected in a monitor, or if not connected in a monitor, then you assess that the patient is having low heart rate, low blood pressure. Then you need to connect to the monitor for the continuous cardiac monitoring. Then, since the monitor just shows few ECG strips showing a few ECG rhythms, we just put 2 ECG strips or rhythms. We do put lead 2 sometimes, and the precordial leads. Just the 2 leads are being displayed in our monitors. So once you see that the patient is running bradycardic, it's very good to do a 12-lead ECG so that it can show the other parts of the heart, what's wrong with the whole heart. Okay, then you need to keep the vein open for resuscitation if it happens that the patient is finally we do
controller amenizima sisikii size presentation ikiendelea.
Baraka. Okay, so finally we do have pharmacological intervention. So whenever the patient is having bradycardia, mostly we just start with the atropines, 1 gram. We can repeat it for 3 to 5 minutes, and the maximum dose is 3 milligram. Then if atropine is not available, we usually use adrenaline or epinephrine as an alternative. Next slide. So the other arrhythmia is tachycardia. So tachycardia is just the heart rate above 50 for the stable adults. So in order to say that the patient is tachycardic, it has to be associated with the symptoms. Okay, the heart rate has to be above 100, but clinically we define tachycardia if the patient is showing the heart rate that is above 150 with the clinical presentation, like if the patient is showing the signs of shock, the mental status alteration, hypotension, etc. So as I've said in bradycardia, also tachycardia, in order to say that this patient is tachycardic, it should be associated with clinical symptoms. Once the patient is having a high heart rate, sometimes it impairs the cardiac output. So the heart rate impairs the cardiac output, and the patient could be showing the signs of poor cardiac perfusion, poor blood perfusion. Next. Okay, we have different types of tachycardia. It can be sinus tachycardia. It means the heart is beating normally, but it beats faster. But when we say sinus tachycardia, it means the electrical activity starts from the senior atrial node, the pacemaker of the heart. Then it passes through the normal conduction ways. Then you have atrial fibrillation. Atrial fibrillation is a faster heartbeat in which the atrium are adjusted. They are not beating. It's just like they are quivering or vibrating. The heart rate could be very high, above 200 to 350, 100 sometimes. The other is the atrial flutter. Also, the heart rate is above 200 to 350. So this can be, the difference can be seen through the ECG. We have the supraventricular tachycardia. We have ventricular tachycardia. The ventricles are beating faster than normal. Then we have YD complex tachycardia. Next, these are different types of tachycardia that can be seen in an ECG. Next. So this is sinus tachycardia. Sinus tachycardia, I said that the impulse or the origin of the cardiac impulse is from sinusoidal node, the pacemaker of the heart. So the electrical impulse is within this the particular pathway, but the heart is beating faster. Next. So this is ventricular tachycardia. This one is one of the very dangerous arrhythmia. One of the very dangerous arrhythmia. The ventricles are beating faster, impairing the diastolic and the systolic phase, impairing the cardiac output. Once you see the heart rhythm like this, it's one of the very dangerous rhythms that a nurse should be recognized through the monitor. Next. Yes, we have atrial fibrillation. Atrial fibrillation, as I've said, the atrium, one of the 4 different chambers of the heart, the atrium now beating very faster, and I've said that before, it's not like beating, they are just quivering, they are vibrating, impairing the diastolic phase, impairing pushing the blood to the ventricles, then to the systemic and pulmonary circuits. So once the patient is having atrial fibrillation, one of the compromise is the same. It's the poor cardiac output and the poor and the presentation of signs of poor perfusions. One of the complication of atrial fibrillation is pulmonary embolism. Once the atrium are beating very faster, can lead to stasis. Then the blood is not moving to the down chambers, the ventricles. It causes stasis. So tunasema damu inaganda. So the blood clots can move to the systemic circuits and cause embolism. One of the dangerous conditions that can result from atrial fibrillation. Next. So this is also atrial flutter. Atrial flutter is one of the dangerous arrhythmias. As you can see, atrial flutter can be seen by these features of sawtoothed character, unakuwa kama meno ya msumeno. If you see this in your monitor, then know that this patient is having atrial flutter, one of the very dangerous arrhythmia. You need to take action. Next. So this is also one of the dangerous, very dangerous arrhythmia. It's called supraventricular tachycardia. So you can see it through monitor or through 12-lead ECG. Then the compromise is almost the same, but the heart rates do differ. The heart rate for SVT, for VT are very high. Sometimes can be even up to 300 to 400 heartbeats. Just imagine the heart is beating up to 300. There is no good cardiac output. So the patient will be showing the signs of poor cardiac output. So the most important thing as a nurse, you need to assess the output of what is being showed in a monitor. So if you see the rhythm like this, you first assess the patient. This is called supraventricular tachycardia. The atrium and the other chambers are beating faster than normal, impairing the normal heart beating and cardiac output, and the whole hemodynamics can be impaired. Next. So management is almost the same of all arrhythmias. Next. So in ICU, these arrhythmias have different intervention. We have pharmacological intervention, but we can also have this called defibrillation and cardioversion. So this life-threatening arrhythmia, one of the intervention is to defibrillate. This can be chipped in deeply next time, but one of the very important management is to do defibrillation. So mostly ICU have defibrillators or the cardioverters, a machine that helps to defibrillate, to restore the rhythms from fibrillation to normal sinus rhythm, so that you can save the patient from getting the signs of poor cardiac output and other complications. So you need to have this. Sometimes you need to have intubation equipment once the patient is having these tachycardias for an emergency. Next. Next. So in ECG, not only arrhythmias can be detected through ECG. In ECG, you can also detect the electrolyte imbalance. Once the patient is having electrolyte imbalance, when the patient is having, let's say, high potassium levels, can be seen in ECG. Low potassium levels, low sodium, high sodium, calcium, magnesium, and the other electrolytes can be seen through ECG. So through ECG, not only arrhythmias, you can also detect the electrolyte derangements. It's quite easy to detect to see that the patient is having high potassium through ECG, low potassium, sometimes metabolic disturbance. Once the patient is having, let's say, metabolic acidosis or whatever, can be seen through ECG. Once the patient is having invasive lines, the arterial lines, etc., can be monitored through ECG. So multiple drug therapy can lead also to arrhythmias. Multiple drug therapy can lead to arrhythmias. The drugs like inotropes, drugs like potassium chloride, etc., can lead to arrhythmias, whether tachycardia or bradycardia. So once the patient is in the treatment of these different types of drugs like inotropes and electrolyte and the other drugs, so it's easy to detect the derangement through monitor. Next. So I've said it before that so continuous ECG monitoring can facilitate a quick identification of these arrhythmias and take action promptly. So it's important to be familiar with the basics of ECG. The basics of ECG as a nurses who are working in a critically ill patient or the other settings can help you to save the patient's life through identifying arrhythmias through ECG. Next. Okay, next. So once the patient is connected to ECG machine or the monitor, there are different factors that can affect the quality of ECG. Once the patient is connected for ECG monitoring, you need to see the clear picture of the rhythms. So there are different factors that can affect the quality of ECG in a patient who is in a critically ill setting. So sometimes placing the electrodes, so the electrode can have poor contact between, there can be poor contact between the skin and the electrodes. The sweat skin and the dry skin. So once the electrode are not touched intact, so can affect the quality of the ECG. You can see that the rhythms are not normal. It's called an artifact. You can see the artifacts. So once you see that the heart rhythm are not seen as it has been to see normally, then one of the factor is if the patient is having sweats, if there is poor contact between the electrode and the patient's body, can affect the quality of the ECG. If the patient is shivering due to different or various reasons, can affect also the quality of the ECG. So sometimes you can interpret that the patient is having an arrhythmia and it can't be arrhythmia as you think. That's why I've earlier said that you need to assess the clinical presentation before interpreting the rhythms in the monitor. So shivering can also affect the quality of the ECG. Next. Okay. Then I think briefly I've done about ECG. So this is just a very basic part of ECG, very basic. In order to understand the ECG, one has to understand the cardio, the physiology of the heart, the electrical conductivity of the heart, so that to understand how the heart functions or how the heart works. So I have to end up here. Then we'll have more discussion about this later on. Thank you.
Thank you very much, Nduma, for the great discussion on electrocardiogram, what it entails to monitor your patient using the cardiac monitor and the looking at the ECG tracing. One very important comment that I hope we could all take away from that discussion is the fact that we should monitor the patient, not the cardiac monitor, so that we are managing the patient and not the parameters on the cardiac monitor. Thank you. Allow us to welcome Marco back to take us through the remaining monitoring parameters for the critically ill patient. Karibu sana, Marco.
Asante sana, Faith. So good evening once again, ladies and gentlemen. So this is now as oximetry part, as a part of our cardiac monitors. Now we are moving from the cardiovascular which is meaning the electrocardiogram and the pulse rate itself. Now we are going to see that the cardiac output was enough to perfuse the organs and other peripheral tissues. Now is where we can now look on the oxygen saturation. So this pulse oximetry is used to measure oxygen saturation in the tissue, as usually known. So it's expressed as the SpO2, ranging from 95 to 100. However, it's not normally 100. That is a normative range. So any follow of SpO2 indicates the development of hypoxia. And this is a very crucial part. Sometimes here as a referral hospital, we just receive patients from peripherals being transferred for a long journey with the saturation of 60s, 70 something. And whatever you ask, why traveling with this patient under this saturation, they said there's someone ordered me to go with this kind of patient, or we didn't have an oxygen. So you receive a patient and then later on has got a permanent disability with the hypoxic brain injury. We call it anoxic brain damage, and that there is no point of recovery at that point. So oxygen saturation monitoring is very, very crucial, as the brain tissue, wherever it goes under deficient of oxygen, for just 5 minutes, it got damage. The damage due to oxygen to the neurons of the brain is of no reversible. Next slide. So before any visual evidence of confusion and unconsciousness, you have to recognize the level of oxygen saturation from the pulse oximetry. So confusion and the changes in level of consciousness comes at another point after you have evidently seen oximetry what is telling you. So any number giving you that number of between 95 to 100, wherever it comes less than that, you have to understand that the tissue again is suffering. And the most tissue which are being suffered from this kind of hypoxia, the first one, the brain. I thought some of us, we know that the oxygen we are taking in, almost 3/4 of it is going to the brain. So wherever the number of oxygen level goes down by any point, the first organ to suffer is the brain tissue. So let's take care with the oxygen saturation. So normal breathing person ranges that I have said. So next slide, please. So however, I have to keep in our mind that for the smokers and those with the chronic lung diseases like COPD, lung fibrosis, the oxygen saturation might be a slightly lower, ranging from 92 to 95. So wherever you get this kind of patient, do not struggle hard to make sure that it is 95, 99 to 100. It won't get there, because of the pathologies of the lung, the physiology of the lung itself. As we are saying that for the like just one with the fibrosis, there is no more lung expansion. So the lung compliance become very, very limited. So even the number of oxygen taking the patients become low. So don't get started to make sure that's above 96. So a patient with the pulmonary derangement have impaired gas exchange, and the result will be low oxygen saturation. So wherever we are talking about pulmonary derangement, we are talking about the patient with like asthmatic patient, those with the aspiration pneumonia, whether it's bacterial pneumonia, acute respiratory distress syndrome, ARDS, pulmonary edema, and even pulmonary embolism also impair this lung, lead to lung derangement. All of this one will impair gases exchange, and the result will be the low oxygen saturation. So you have to think on the dangers of hypoxia. One of the most dangers of hypoxia is the brain damage. This is the very, very complicated. Apart from that, you have it is lead to derangement in metabolic activities. So wherever you derange metabolic activities, meaning that the tissue is suffering from hypoxia, changes from aerobic to anaerobic respiration, starting metabolizing fats and the other protein, leading to production of pyruvate and going into the Krebs cycle, producing some chemicals like lactic acid, which is very complicated and may lead to death. So wherever we're talking about hypoxia, again, you have to know that the most risky is immediate cause of cardiac arrest due to the hypoxia. So wherever the patient you see on the pulse oximetry, the reading is less than 90, you have to be serious looking for the patient. Make sure that you oxygenate the patient as much as you can. Next slide. So most oxygen saturation just display values of heart rate. You'll see. In most cases I have tried to visit, you find the patient has a pulse oximetry only. So through that pulse oximetry, they are looking for oxygen saturation and the heart rate. So however, wherever you're using the pulse oximetry, you get the number of heartbeat. So this heartbeat is connected to the audible tone. And this tone pitches changes due to the oxygen saturation level. So wherever you find that the tone has changed, the pitch has changed, look to your patient immediately, because it might be a severe and a serious hypoxia. And the intensity of this pitch increases that the oxygen goes down. So you have to be careful with this tone from the pulse oximetry. It gives a valuable information about hypoxia, and wherever the oxygen is going down, even the heart rate goes down drastically. So whenever you hear the pitch has changed of hypoxia, you have to take to keep in your mind that even the heart rate now is going down. As Mr. Joshua has said a lot about the bradycardia and its cascades, you find the complication, the patient will be in danger. So to keep the patient safe, you have to interpret this pitch sound related to oxygen saturation accurately so that you can save your patient. The next slide. So we are talking about the connection of the pulse oximetry and the heart rate. So from the monitor, due to that connection from the pulse oximetry, we're looking for the graph presentation, which known as plethysmograph. This is a pulse waveform on the screen of the monitor. This gives information about the quality of the signal strength of saturation detection. So wherever you see this, why do we get pulse rate from this oximetry? Is due to this signal strength from the plethysmograph, which gives the picture of pulsation. So the strength of pulsation that gives us this signal strength. So good signal indicates well perfused tissue with a good temperature distribution. So weak or absent signal, it alerts you to assess patient perfusion and the blood pressure. However, cold extremity again, I thought it may be due to this hypoperfusion, also can affect the quality of signal strength. Sometimes the pulse oximetry, they didn't peak the oxygen saturation due to that poor perfusion and the coldness of those extremities. So you have to know with this kind of information. Next slide. So what oximetry tells you about? So this tells you about the oxygen delivered to the tissue, and this oxygen delivered to the tissue is being dictated by the hemoglobin level and the cardiac output. Wherever we're talking about the hemoglobin level, we all know that hemoglobin is the one who scales oxygen molecules to the tissue. However, it has a lot of factors affecting this hemoglobin to scale a sufficient number of oxygen. Again, the cardiac output, meaning the amount of blood ejected from the heart going to the tissue with the oxygen. So oxygen saturation is determined by both breathing and the ventilation. So it's here again, we have to think on the difference between breathing and the ventilation. Breathing is just the mechanism of taking air in and out, while ventilation, this refers to the exchange of oxygen at alveolar level. So where the oxygen is in and the carbon dioxide out from the blood stream. So this is being determined by the perfusion to the lung capillaries. This is very important to think of that. So in corridor shocked patient, place a probe on the other part of the body. You can place on the earlobe, you can get the readings. However, coldness impairs the quality of signals, as I've said before that. Next slide. So what are the factors influencing the oxygen saturation? Of course, movement of the patient himself or herself may lead to to get poor oxygenation due to probe placement, incorrect positioning of the probe as well, hypothermia, as I have said, to affect the signal strength and prevent the pulsometry from peaking the signal strength and interpret the level of oxygen. Hypovolemia as to affect the perfusion of the tissue. Again, vasoconstriction as well, vasoconstriction affect again the perfusion to the tissue. The nail polish, it may absorb the light waves used to measure SpO2, and thus will affect the quality of oxygen saturation level, as well as the oximeter itself might not be working properly. So wherever you find the oxygen saturation of the patient is down, you have to think or troubleshooting what might be the problem. And if you find the problem with the patient himself, you have to take it seriously. But first of all, we have to assess the patient and then go to troubleshoot to the machine and the probe itself. Next slide. So from the oxygen monitoring through oximetry, there is another parameters which is very, very advanced, and this is a very important one. As end tidal of carbon dioxide monitoring, it is so too, or sometimes you call it easily carbon dioxide monitoring. Most of patients in our ICUs and in our other settings are not being monitored with this carbon level. Usually, even the effectiveness of ventilation are being measured by using oxygen saturation. Well, you might ask somebody, so why this patient doing this? Well, is saturating well, regardless the work of breath and other features of distress and so on. So measured by using sampling line, and this monitoring analyze the gas and the value are displayed on the screen. This can be done by both for intubated and the non-intubated patient. So the normal TSO2 ranges from 35 to 45 millimeter of mercury, and this will give you the normal acid-base status. However, for the patient with the traumatic brain injury, the level of this TSO2 is being recommended from 30 to 35. This is normal because the carbon dioxide level in our body has something to do with the cranial vessels for the case of vasodilatation and the vasoconstriction to make sure that the perfusion to the brain is adequate. Next slide. So what are the information obtained from the carbon dioxide level? First of all, it gives you acid-base status of the body. How? We all know that whenever you have accumulated a lot of carbon dioxide into your body, as from the normal universal buffer equation of carbon dioxide plus water, making something bicarbonate and hydrogen ions. So as you increase the number of carbons in our body, you are deranging the acid-base status, as well as you decrease the number of carbons in our body, you are deranging the acid-base balance again. So we all know how the tissue works under normal pH. So this is very important. Again, the carbon dioxide give you real-time respiratory status. So sometimes our patient might undergo respiratory arrest. We fail to detect. Wherever somebody stops breathing, oxygen saturation takes up to 7 to 18 minutes to start dropping. But the carbon dioxide, especially through the capnograph, as we will have to see on the next slide, will show you immediately that this patient has stopped breathing. So you can even take action immediately. So again, it gives you information about ventilation. As you can see, the adequate number of carbon dioxide level and the graphical presentation of that carbon flow will give you that the ventilation, meaning that the exchange of carbon dioxide and oxygen at the alveolar level is taking place adequately and as required. Again, to tell us about metabolic activity of the patient. Sometimes patient might have a large number of carbon dioxide. It's not associated with the pulmonary activity. However, it might be due to increased metabolic activities, meaning that more carbon dioxide are being produced in the body. However, patient might have low metabolic activity, presenting with the low level of carbon dioxide in the body. That is very another case again. Again, for intubated patient, carbon dioxide and capnograph itself help us to confirm the placement of endotracheal tube, the ATT itself. This is very important. Sometimes patients are being intubated on the esophagus and they are being ventilated. and to the point where you find that the abdomen is very distended, getting, and sometimes they get hypoxia due to that poor placement of the endotracheal tube. So wherever you use the carbon dioxide, it's easier for you to confirm that the tube is in the trachea. If you place the tube in the esophagus, you won't see the carbon dioxide and the capnograph as we'll see later. Next slide. So this is the capnograph I was trying to talk. This is a graphical presentation of the carbon dioxide, the inspiration versus expiration. Usually, it provides continuous carbon dioxide waveform, usually plotted against time. And this has 4 phases. You have phase 1. This is a very isoelectric line here. This in the phase 1 indicated the inspiratory time. During breathing, taking air in, no carbon dioxide is coming out. So you will have this isoelectric line. So phase 2 indicated the initial of expiration, where the number of carbon dioxide is starting to build in the sampling line. And the step 3 show the plateau phase, where the maximum expiration. So you detected the maximum number of the carbon dioxide during the course of expiration. And the phase 4, this is a peak. And at the phase 4 is where we now detect that number we mentioned, 35 out of 45 at the end of the last phase. This is initial of inspiration or end of expiration, where the carbon dioxide is starting going down in the sampling line, and it become again at the baseline where the inspiration takes place. So we all have the concept that inspirational phase is very short compared to expiration phase, and it's carbon dioxide waveform again proving that. So for the patient who has stopped breathing, you want to see this kind of this graph. You will see the isoelectric line, the flight line, as the one we usually see on the assist phase. So if somebody stops breathing immediately, the graph flattens to isoelectric line, meaning that no giving out carbon dioxide, meaning no ventilation, and you need to take it seriously. If you are relying on oxygen saturation, the oxygen saturation will take much longer time to start dropping. As I have said, 80 up to 13 minutes, you will start looking oxygen saturation dropping down. So capnograph will tell you within a few seconds of somebody stopping breathing, the graph will flatten immediately. However, the number of carbon dioxide as it will being displayed to the monitor will drop after 3 seconds, but milliseconds, the graph will flatten immediately. So it's important to connect the patient with the capnograph, as most of our monitors we have currently is very advanced with this advanced technology of carbon dioxide monitoring, as it's used to measure the effectiveness of ventilation. Next step. So this is just a meaning of this end-tidal carbon dioxide level. So for the low level of carbon dioxide, less than 35 millimeters of mercury, meaning that you are hyperventilating, you are increased respiratory rate, hypocarbia. This favors alkalotic state or alkalosis. It might also be due to decreased metabolic activity, as I have said to the previous slide. For the high level of carbon dioxide, above 45 millimeters of mercury, meaning that you are hyperventilating, and this usually happens to the patient with apnea, or maybe sometimes you might have weak respiratory effort, and you have to. Okay, so this defines hypercarbia and favors acidemic state, meaning acidosis. Also, it might be the indication that the metabolic activity has increased into our body. That's meaning that the carbon dioxide production is high. Next slide.
Marco, thank you for the presentation so far. Great discussions there. Let me ask, for the sake of the time we've consumed so far, how many more minutes do you need? Because members have questions. Several have been raising hands. How many more minutes before you conclude so that we can take questions?
Just 10 minutes. I have to to go through very, very important parts. 10 minutes enough, so that at 40 we have to release the discussion. We are very sorry for the long presentation.
Thank you, Marco. Thank you. Continue for the next 10 minutes. Thank you.
Next slide. So this another part of patient monitoring, the blood pressure. I think you all know that's the pressure exerted by circulatory blood on arterial walls. This provides important reflection of the blood flow when the heart is contracting, the systole, and relaxing the diastole. So what we are looking for here, the systolic blood pressure, the diastolic blood pressure, and the mean arterial pressure, the MAP. This is a very important part of monitoring. And we are very concerned with the MAP because this is the one which determines the organ perfusion. The MAP ranges from 70 to 100. However, the literature says 60 to 100. But wherever you find the MAP is less than 60, that's the very dangerous situation. Somebody might have very low blood pressure, as you can say. That's why we are limiting the use of normal blood pressure. Which is normal, you have to specify. If it's 90 over 41 and the MAP is 73, that is normal to that kind of guy. However, might have been the signs of shock, but you don't want to rush and hurt yourself running for resuscitating this kind of patient. But if you find the patient with the systolic blood pressure of 90 and the diastolic of 41, with the MAP of 57, this is very dangerous. You have to learn making sure that you resuscitate the patient because that MAP is indicating that even the organ are not well perfused. So the risk of organ hypoperfusion is very high and the organ damage. Next slide. All of this has been saying that so changes in the blood pressure can be reflective of underlying pathologies. So body attempts to maintain hemostasis. So you have to think on the ranges in accordance with the age. So wherever you see changes in the blood pressure, you have to take action, making sure that these changes might have a lot of complication to the patient. So these are the factors influencing blood pressure. One of it is cardiac output, as we all know. This cardiac output is ejected during the systole, which is contraction phase of ventricles, and is where we get the systolic blood pressure. So if the cardiac output is low, expect even the blood pressure will be low. Peripheral vascular resistance as well, as it might be affected by some of pathologies, as has happened in different type of shocks. You can get this vascular resistance might be low or might be increased. This will also influence the blood pressure. The blood volume itself, as we usually see in hypovolemic shock, or somebody with you lost the body fluid, blood, vomiting, diarrhea, whatever the case, you will reduce the volume of circulating body fluid, including blood, and the blood pressure will be affected. Again, the blood viscosity, as well as blood vessel wall elasticity. These are some of the issues affecting the blood pressure. Next slide. So this is some summary. Decrease in blood pressure often seen in patients prior to cardiac arrest. Sometimes you find that sudden cardiac arrest, but sudden cardiac arrest has its prior indications. Wherever you are monitoring the patient correctly, you find though these issues you will get about that. So hypotension, if not attended, can lead to hypoperfusion to the vital organs and lead to even cardiac arrest, as well as hypertension. If the blood pressure is very elevated, meaning that you have to cross-check. This blood pressure may be elevated due to inappropriate cuff size you are using. You have to look for your cuff size, if it is of the appropriate size or not. If it's small, it might give you a long reading, and you might have misinterpretation of the patient vital parameters. Sometimes with the blood pressure can be measured non-invasively and invasively. However, in most cases, we are monitoring this patient with the non-invasive monitoring. So invasively is very advanced technology using arterial lines inserted in large blood vessel, such as radial or femoral artery. And this is being done in some large hospitals only. Move on. So respiratory rate. This might be the end of for me today. So this refers to the number of breaths calculated over 1 minute. However, this respiratory rate ranges from 12 to 20, it depends, per minute. But in most cases, respiratory rate is one of the vital signs which is not being monitored by most of our clinicians, our nurses. And I think this is because they think it's of no importance or whatever, I don't know. But respiratory rates are being left behind. However, respiratory rates just give you a lot of crucial information. So decrease or increase in the respiratory is the most sensitive, as it can indicate a clinical deterioration, impending adverse events such as cardiac arrest and the death to sometimes. So respiratory rate, if it's high, it's mostly that maybe it's giving you the clue that the carbon dioxide built up in the body is high. So you are trying to get rid of carbon dioxide, you have to hyperventilate to minimize that number. So wherever you find the respiratory rate is high, please you have to take action. And one of the most action is to support oxygen with the patient with the oxygen, regardless of oxygen saturation. For the oxygen, for our respiratory rate above 24 cycle per minute, you have to give a patient supportive oxygen regardless the oxygen saturation. However, some points you find the patient has a RR of 38 up to 40 something. You ask why not on oxygen time on tells you, oh, his saturation is okay, 96. So 96, but the patient has increased respiratory rate, meaning that something has drenched. You need to help compensate with this kind of drenchment. So we have to think on that angle again. Next slide. So this is just interpretation of this, which is very common to everyone. So however, I can talk a little bit on bradycardia, bradypnea of RR less than 10 beat per cycle per minute, or the cycle per minute, not beat per minute. This might be caused by drugs like opioids, hypothermia, and other things. However, drugs like diazepam, again, we usually give them patient, or this can lead to bradypnea, which is very bad. Again, the fatigue, central nervous system depression for the patient with the cerebrovascular accident, whatever is the pathology or traumatic brain injury, brain tumor, strokes, all kind of strokes, all these are central nervous system depression. Again, the neuromuscular diseases which affect even the respiratory muscles, again, might lead to this low respiratory rate. Like myasthenia gravis, Guillain-Barré syndrome, these are the complications of this one. They just bring, even affect the respiratory muscles. So leading to bradypnea. So very, 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 very challenging. So whatever it is done, you have to assess your patient as much as you can. Next slide. So whatever you are looking for the respiratory rate, you have to assess even the respiratory pattern of the patient. Look for the chest movement. Are the air entering or not entering? Chest rise, is that symmetric or asymmetrical? If you see the significant chest rise, meaning that the patient is getting adequate tidal volume required for the body physiology. Again, wake of breath. And here is where we have to distinguish between wake of breath and the use of accessory muscle. Wake of breath usually is being seen when there is increased or decreased effort. When do we say the patient has increased the effort? Is usually when we see the vivid use of abdominal muscles. As we all know that the respiratory muscles as divided into 3 groups. We have active muscles, passive, and accessory one. The active one, we know this is also diaphragm and intercostal muscles, both external and internal. And we have passive muscles, which are the abdominal muscle. And wherever you are sitting, whenever you are seated there, you can see you are breathing, and there's some muscles of abdomen are moving very shallow. When you start using your abdominal muscle actively, is where we say that the wake of breath has increased, the effort has increased. And when we are talking about use of accessory muscle, is when we are using the accessory muscles which are not supposed to be used at normally. These are the sternocleidomastoid muscle and the scalene muscles, all are found in the neck. So when you find the patient is breathing using neck muscles, this is a very dangerous state, need immediate intubation. Need immediate intubation because no other alternative. So RR consideration, so wherever you increase the RR indicates hyperventilation, meaning that you are giving out much carbon dioxide. so you get into alkalotic state, so acid-base derangement. And whenever you decrease your RR, you are hyperventilating, you are retaining carbon dioxide, you end up in acidemia. So the acidosis, which is very fatal, and it can cause cardiac arrest immediately. So risky for this one is hypoxia, leading to anoxia and anoxic brain damage. So respiratory failure is a state of emergency, need immediate intervention. This slide, with the time still with me. So this pulse rate, I thought Joshua has said something about this during the ECG and the pulse rate. So I can move. The next slide. So this is the body temperature, which is defined as the balance between the heat produced and the heat lost, the thermoregulation. And in our critically ill patient, whatever we are monitoring the patient, relying on the auxiliary one. However, the rectal and the oral temperature are being considered as the core temperature, but we are not usually measuring the auxiliary temperature, which are being affected by surface and the exposure of the patient to the environment. So the temperature of the body is again a very important parameter to monitor. As the temperature goes down or high, it might affect the metabolic activity of the patient, as well as it affected the oxygen carrying capacity of the patient, and they may lead to cardiac arrest as well. So temperature again is very important to monitor during the patient monitoring. Next slide. And this that's are the some factors affecting the body temperature, as the infection or sepsis might increase the body temperature, skin exposure to corroding
One more minute, Marco.
So maybe to that point of 1 minute, I have to say sorry for everyone who joined for this session, because the session was a little bit large and we failed to manage much more time according to the situation. Some of parameters has remained uncovered. Hopefully we will have another session next time if God is gave us a chance. Thank you for listening. Let's end up there.
Thank you so much, Marco, for the great discussion. We all appreciate the very important points that you've put across within a very short period of time. And we must all acknowledge the fact that all the things is discussed. We take a lot of classes in critical care just to cover a lot of things that is mentioned in a very short period of time. But we'd like to engage the participants in terms of receiving and responding to their questions by our key presenters and also by the rest of the team. And then if we have 1 or 2 minutes left before the time clocks 9, then Marco can give us a summary of the parameters that he has not covered. But for this moment, let us allow our participants to raise their voice to the discussion. And one question that has been raised is, how does hypothermia or hypovolemia influence the saturation of oxygen? How does hypothermia or hypovolemia influence the saturation of oxygen? Marco, do you want to respond kindly?
It's okay. How does hypovolemia affect saturation? Is that right?
Yes. How does hypovolemia and hypothermia affect SpO2?
Yes, let's start with the hypovolemia. Hypovolemia refers to the reduced circulating volume. And if somebody has reducing circulating volume, meaning that the perfusion to the tissue will be low, meaning that is hypotensive in such a way. So the hypoperfusion will reduce the signal strength to the peripheral tissue, and the pulse oximeter will fail to detect such kind of signal strength, and they fail to display the value of oxygenation to the tissue. As I have said, that the oxygenation to the tissue is being detected by pulse oximetry, and this can be affected by hypotension, which is being defined by that was said. For the case of hypothermia, meaning that the temperature distribution is due to the perfusion again. So wherever somebody has a very, very cold extremity, the signal strength will be very, very weak. So the pulse oximetry will not even able to pick the signal strength again, and it won't give you the significant number of oxygen saturation to the tissue.
Thank you, Marco, for that response. And let's also remember the effect of hypothermia on the oxygen hemoglobin dissociation curve that increases the affinity of oxygen and at times gives us a false value in the pulse oximeter reading. So every time you have an hypothermic patient, kindly try and get a blood gas analysis. It will give you a better arterial oxygen saturation for the management of your patient. Our next question is, how do we support those who are working in those hospitals where there are no supportive devices for monitoring? How do we kind of support people working in facilities where there are no monitors? Anyone from the administrative section in your hospitals could respond to this. How do we support those who are working in areas? Yes, please, Marco, go ahead.
I can give a clue for that. One of the supports is giving information like this one. Wherever you are knowledgeable with something, it's easier for you to demand for it. Sometimes we get challenges of asking for the authorities to bring those advanced equipment, monitors, whatever we are going to use, because we don't have the information about it. We don't know how to use. We don't know that is very important. So it's difficult for us. So one of the support we are making here is this kind of sharing this information, so that after getting this insight, you can now start looking for what can I get now to help my kind of patient. However, authorities are very eligible and they're committed to make that available to all patients.
Okay, Madam Faith.
Go ahead, Emmanuel.
Madam Faith.
Yes, go ahead.
Yes, for me, I think we have something we can advocate, because we see that the presentation is very nice and we have learned a lot of issues concerning with the devices that we are looking to have advocacy and support. There are some hospitals that need more supervisions in case of these issues. So I think as presenters, probably because they have the causes, they learn the short course of this critical care issues, whatever it is, they have a chance also to advise the supervisor bodies, including Ministry of Health, also the other investors, to think about the hospitals that lacking some of these devices. Because some of the reports, when we write to them, they take it as a gap and they are looking how they can work on it, because it is very important to have these kind of devices around some of the hospitals. So my request for those presenters, because they learn this course, they can even attach some of the recommendations to the Ministry of Health to look on some of the hospitals, that it is very important to support devices or to look on the possibilities of supporting them, because we have these patients from the different areas. It is not only the largest hospital, even those low-level hospitals, also they receive the same patients. And sometimes it's quite difficult to attend these patients because we lack some of the important devices like a monitor. So I think it is a time. Our presentation should be parallel with having the reports that can be shared as a part of the gap to the responsible ministry and other bodies to take the consideration of those areas. Thank you very much. I wanted to add on this.
Thank you, Marco and Moses. So let us combine the knowledge that we have and advocacy. Very, very important. But the most important thing is, let's begin by recognizing that our patient is deteriorating and we need to escalate the care. Escalate the care as soon as possible to save that life. Thank you for that response. Another question from the participants is, for a patient with respiratory distress but has a normal saturation, what intervention do we do? You're having a patient who is in respiratory distress, but their saturation is normal. What do we do? You can go ahead, Marco or Nduma, whoever is willing to respond.
For the respiratory distress, but is saturating normally, what to do? So what are the features of respiratory distress is where we have to start. First of all, is increased respiratory rate, increased weight of breath. However, you have to assess the depth of breathing, whether it's shallow or deep breathing. And in most cases, you find them with the very, very shallow breathing. So first thing to do, before anything, you have to support this patient with oxygen. After there, you have to go and looking for if you have a capnograph, you can connect the patient to the oxygen system and then carbon dioxide to look out the level of carbon dioxide. And you have to start looking out for any kind of acid-based derangement, especially during the ABG, as said. But however, the first thing to do, make sure you keep patient on oxygen regardless the oxygen saturation.
Thank you, Marco, for that response. It's very important. Thank you. In addition to what he said, it's very important to note that you can have a normal pulse oximetry reading, that is the SpO2. But when you do your arterial blood gas, you realize that the arterial oxygen of blood, which is the very important parameter to note in terms of ventilation and perfusion, is low. So you do not have to entirely rely on the pulse oximeter reading. If you are noting that something is wrong in your deteriorating patient, please obtain an arterial blood gas analysis to check for the actual arterial oxygen saturation. But in addition to what Marco said, please note that the ABCD approach is very important. Your patient could be in respiratory distress because something is obstructing their airway. Whether they have an advanced airway or not, there could be an obstruction to that airway that is causing them to be in respiratory distress. So look at your ABCDE and intervene appropriately so that you can save that life, not just rely on the pulse oximeter reading that it gives you. Thank you. So the other question is, how does atrial fibrillation cause blood stasis and ultimately embolism and stroke? How AFib or atrial fibrillation leads to embolism and stroke? Nduma, are you still with us?
Yes, I am here.
Go ahead, please.
Okay. Thank you for the question. The question is how atrial fibrillation causes. Can you repeat the question, please?
Atrial fibrillation causes blood stasis, ultimately embolism and stroke. How I think in simple terms is how AFib is likely to lead to embolism and stroke.
Okay. Thank you so much. Okay, thank you for the good question. Yes, as I've explained before, how AFib can cause stasis and finally embolism and stroke. Okay. So the reason behind is I said that AFib there is disorganized atrial contraction. The atrium, the upper chambers of the heart, beat irregularly and fast. So this can lead to ineffective contraction. So it impairs the normal cardiac cycle. So it disrupts the normal blood flow of the heart. It disrupts the blood flow to the ventricles. So what happens is the blood remains in the atrial chambers for a bit long time than it's supposed to be. So the staying of the blood at the atrial chambers in more time than it has to be is what we call stasis. So once the blood stasis happens, it increases the risk of blood formation, the thrombus. So it has some phenomenon which explains this. It actually causes the hypercoagulability. So once the blood stasis happens, what happens next is once the heart keeps on beating, it can disrupt the clot. It can disrupt the clot, and then the clot can travel through the blood system to the brain, where it can finally cause a stroke. So simply is the stasis itself, the irregular beating of the atrium that causes the blood, the disruption of the normal flow of the blood to the ventricles, then the disruption of the thrombus, which travels through the blood system to the brain, then finally stroke. Thank you.
Thank you very much, Nduma, for that concise response. Another question is, what is the difference between supraventricular tachycardia and ventricular tachycardia? Could you kindly explain the main difference between SVT and VTAC?
Okay, thank you so much. So the SVT and VT, as I explained before, they are all the dangerous arrhythmias. So there is difference between SVT and VT. So The SVT, as the name itself suggests, it's supraventricular tachycardia. It means the the problem originates above the ventricles. So typically, supraventricular tachycardia originates above in the atria. So sometimes it originates from the atrioventricular node. So the first point is SVT originates in the atria above the ventricles, and the heart rate for SVT is usually from 150 to 50 beats per minute. For ventricular tachycardia, actually it originates in the ventricles. The difference, it originates in the ventricles, the lower chambers of the heart. But the heart rate for the ventricular tachycardia varies from 120 almost to 250 from the literatures. So the supraventricular is actually from 150 to 250 and above. But for ventricular tachycardia, it can sometimes start from 120 up to 250. Okay, but the other difference it is from the presentation. For the patient with the supraventricular tachycardia, mostly they experience palpitations, dizziness, shortness of breath, and kind of chest pain. And for the ventricular tachycardia, the symptoms could be the same as those of SVT, but the notable difference is in ventricular tachycardia, the chest pain is even worse than the SVT, but the other signs are the same. The other difference is within the ECG itself. How do ECG looks like, the VT and the SVT? So in SVT, most of the time we have the narrow QRS complex due to actually the rapid contraction of the ventricles, but and it's quite difficult in VT to see the P waves, to note the P waves. You can't see the atrial contraction exactly. On the VT, on VT, the ECG actually it has wide QRS, and actually yes, they both had wide QRS, but in SVT, you can see that the P waves is a bit merged to T waves, but in VT it's quite different to see the P waves. Thank you.
Thank you for that clarification, Duma. And just to note, in most cases, you might have an SVT that is a narrow complex, except for some instances, but a VTAC in almost all cases have a wide QRS complex. I think that would just be important to note. But every time you have a VT, kindly check for the pulse, because the management changes if it's a VTAC that has a pulse or one with no pulse. So it's very important to check. Someone is further asking for elaboration about the AFib, and if I could just respond to this about the confusion in terms of atrial fibrillation causing embolism. An atrial that is fibrillating, it is simply quivering, but it is not kind of the atrium is not contracting enough to push the blood out. That is one principle we have to note. It is not squeezing enough to push the blood out, but it is simply fibrillating or quivering. So it is that quivering that leads to the stasis that we see in atrial fibrillation, increases the probability of forming an emboli that could easily break off to the brain and cause stroke. So remember, yes, the atria are fibrillating, they are quivering, the rate is fast, but it is an ineffective rate because they are not squeezing to push the blood out from the atrium. I hope that kind of explains. Yes, they will have tachycardia as a compensatory mechanism because this blood is not squeezed to go to wherever it is supposed to go, but it is that stasis that leads to the formation of that emboli that might dislodge to the brain or to even the lungs and cause massive pulmonary embolism. So I hope that makes sense for the person that was asking that question. Then someone else is giving a scenario. They encountered a patient who had been saturating at 88% on room air, and this respiratory rate counted normal, and they looked very normal. This left me surprised when I asked how this could happen. I found no clear answer. I'm requesting for an understanding of this or any explanation. Marco, would you want to respond to that scenario? Marco, kindly.
Yes, I can respond to that. That the patient is circulating 88 with a normal respiratory rate, thought and the pattern. Yeah, it might happen, as it was usually happening during the COVID era, the COVID-19 eras. So sometimes you might find that the patient is desaturating due to different. There are a lot of factors affecting oxygen saturation to the tissue. One of which is transportation, again, extraction, and the consumption of oxygen to the tissue. So somebody might be desaturating due to the fact that the perfusion to the lung capillaries is very, very minimal. So you are breathing in, taking oxygen in, but at the alveolar level, the oxygen are being exchanged, but are being not taken from the lung level to the circulation. So you might be at was being seen during that kind of situation. So it might happen due to that kind of situation. And what you have to do, if you have a good source of oxygen, you have to support with oxygen and start looking what might be the real cause of it. However, you have to assess again if the desaturation might be due to the reduced cardiac output, poor peripheral perfusion, coronary extremities, and all this can give you that kind of readings. So you have to assess all kind of those issues. If you find that the patient had the warm extremity, the pressure is within a normal range, but the perfusion to the lung is not adequate, so you might have that kind of desaturation reading. I thought that.
Thank you, Moses, for that response. In addition to what Moses said, if you are having a patient who has had chronic obstructive pulmonary disease or its symptoms, it is very okay for that patient to be fine with a saturation of 88%. In fact, it is normal for those patients to have a saturation between 88 to 92%. You should not target, even if they're on supplemental oxygen, do not target to take it above 92%, because that way you kind of block or obliterate their breathing mechanism, because it is the carbon dioxide retention in those patients that triggers their respiratory center. So if you give them extra oxygen and blow out a lot of carbon dioxide, you're kind of blunting their respiratory center response. So kindly note, if you're having such a patient with those COPD symptoms, it is very normal for their saturation to be that way, and they'll be very okay, especially if you are managing rural women who are used to using firewood for cooking, and they have done this for years and years, and is an elderly woman coming to the emergency department, and you see the patient is okay, they are seated, they are not in kind of bending forward, trying to demonstrate air anger. Do not struggle to give them a lot of excess oxygen. But it could be a patient who has suffered restrictive lung diseases from the past. Some of them are used to having low saturation levels. So kindly try to get history and understand what has been the baseline of this patient before you start pumping into them extra oxygen. And if possible, you can do a blood gas analysis to see what their arterial oxygen content are like before you start aggressively supplementing their oxygen. But it doesn't harm to just put them on nasal prongs and begin at 2 liters per minute going forward as you rule out your ABCDEs and ensure that your patient has no life-threatening conditions as at that point. A lot of people are asking that if we could add time, I'm hoping that the participants are in support for the addition of the time, because we are 8 minutes past the clock. So if it is okay for the participants, there are various people that have their hands raised. and they would like to ask an explanation in regards to how hyperkalemia, hypernatremia lead to cardiac arrhythmias. Nduma, would you take this? How hyperkalemia, hypernatremia can lead to cardiac arrhythmias?
Okay, thank you so much for the good question. How can hyperkalemia, hypernatremia can lead to arrhythmias? Okay, so this is about the concept of electrophysiology. So hyperkalemia, it means the high potassium levels. So from the electrophysiology concept, we usually have potassium inside the cells. So potassium being inside the cells, it maintains the resting membrane potential. So hyperkalemia, when we say hyperkalemia, it means now the potassium are much more outside the cells. So this scientifically affects the action potential. So it affects the depolarization and the repolarization phases in the cardiac action. This is a bit deep science, but I think they can understand. But what is being affected is depolarization and the repolarization phases in action potential. So this can lead to prolonged repolarization. So the prolongation of repolarization can lead to abnormal conduction. So in hyperkalemia, you can find that the ECG showing the peaked T waves, sometimes the prolonged peer intervals, or sometimes if the potassium is much higher, you can see the widened QR complex. So the same in sodium. Actually, sodium, we know that sodium is much found outside the cells. So once the patient is having hypernatremia, it's kind of an electrolyte imbalance, which also affects the electrical activity. So once the patient is having hypernatremia, it means the sodium level is almost more than 145 and kind of. So the same phenomenon happens. It affects the conduction. It affects the action potential of the myocardial membranes. But also in terms of sodium, we know that the sodium actually affects the fluid balance and sometimes the osmolarity of the body itself. So this can direct impact on the cardiac arrhythmias. Thank you.
Thank you, Duma, for that response. I think it all boils down to, for the heart to function well, there is the electrical activity of the heart that dictates the mechanical activity of the heart. And electrolytes play a very key function in terms of regulating how these things happen. And the action potential, as Duma said, might seem to be like a complex thing, but it is simple. If Mofate core team or the secretariat allows us another session on electrolyte imbalances, we might explain it well without rushing and ensure that all members understand, and also emphasize on the fact that nurses need to relate to the electrolyte panel of the patient, because so many things go wrong. In fact, hyperkalemia will kill your patient faster than hypovolemia will kill your patient. So we need to understand those electrolyte imbalances and how they affect the electrical activity of the heart and many other functions of enzymes in our bodies. So once we allowed that time, we'll be glad to discuss about electrolyte imbalances. For now, because of time, allow us to move to the next question. There's a question on opioids and bradypnea, or reduced respiratory rate, how we manage patients that are in pain and they are also having a low respiratory rate. And I think Marco would respond, but I begin by saying that, yes, we have analgesics that can affect the respiratory rate. Thinking of your opioids, thinking of your benzodiazepines. But for a patient that is in pain and they have issues with their respiratory rate, you could consider analgesics that do not tamper with the respiratory rate. Any addition, Marco?
I've said, because of the analgesia has a wide range of this drug we are using. However, we have also another opioids. The most of analgesia we are using here is morphine, and fentanyl being powerful analgesia used in the ICUs, again with the pethidine. However, the dominance of side effect on the pulmonary system, some of them preferring morphine, others preferring fentanyl, and some are using of midazolam. But in most cases, you find the patient are being given sedative only without analgesia, which is another case of complication. However, every drug has its special consideration. So you can use even ketamine, but what about the blood pressure? So it depends on what you are using on. But careful monitoring of a patient after every medication is very important. That's what I can say. There are a lot of information needed to be discussed about medication and the drug consideration. That is a special, another discussion which you might have maybe in the next days or months to come. The drug medication and the drug consideration. This is a very important part. It has a lot of complication again. So we need a further discussion on that again. I can say that.
Thank you, Mark, for that response. If your patient is intubated and ventilated, do not be afraid of giving them the high doses of morphine or fentanyl or domicam. It is safe because they are intubated and ventilated. But your patient who do not yet have an advanced airway, then you've got to titrate your opioid or benzodiazepine doses or use an alternative in terms of analgesia. I think that is very important to note. People asking for the notes. I'm sure Moses will share the notes after this session. And then I'm just trying to see if there is any other question that we've not responded to. Yes, people need sessions on electrolyte imbalance and the ECG. Hopefully we'll get that session soon through the Mofate Secretariat. People are happy that they have increased knowledge on the issue of cardiac arrhythmias. That is good. People need a separate session on high alert medications. I totally agree with the team. People are happy that they're expanding their knowledge. We really appreciate that, and we hope that all this knowledge will translate to quality patient care and the best possible patient outcomes. Several people had their hands up. If you have a burning question, you can kindly unmute. Let's use the next 3 minutes so that we stop at 20 minutes past the hour. You can kindly unmute, and after unmuting, be precise with your question so that the key speakers could also respond to it within the few minutes left before we hand it over to the Secretariat and to the President. So kindly unmute if you have a burning question. Let's have only 2 for the sake of time. You can unmute if you have a burning question. Someone is asking what is meno ya musumeno. I think they were referring to the ECG tracing of the sawtoothed tachycardia. Nduma, would you want to explain? I'm not very good in Swahili. What is meno ya musumeno?
Okay. Yes, I was explaining about the difference between the atrial fibrillation and the atrial flutter, the ECG features. So in the atrial flutter, the waves looks like meno ya msumeno. Nadhani mnanielewa. Msumeno ule wa kukatia mbao au si mti, yale meno yake. Kwa hiyo atrial flutter inakuwa na ile features, inakuwa ina zile QRS complex kubwa, afu katikati anakuwa kama meno ya msumeno. That's the difference you can see in atrial flutter compared to atrial fibrillation. Asante.
Thank you for that very precise response, Nduma. And just in summary, so that we hand it over to the Mofate Secretariat, I'm not sure I've seen any other pressing hand up, not unless I forgot to mention you. Ignas, are you saying something? Ignas, are you saying something? I want to give a summary of the discussion today and hand it over to Mofate Secretariat. Okay, thank you. So today we've covered the basic physiologic parameters that we monitor for patients that are acutely deteriorating or for critically ill patients. And key to note that we had a deep dive into ECG and arrhythmias and how to manage them. And we also had a discussion on the issue of pulse oximetry monitoring, the end tidal carbon dioxide, blood pressure, respiratory rate. We did not get to dive deep into the level of consciousness. We also had a discussion into the issues of temperature and what factors to monitor for, and pulse rate. But generally, it was a good discussion. Thank you, Marco and Duma, for the great work. You did well. We are so proud of you and the rest of the participants. But one key take-home thing is our patients who are acutely ill deteriorate very fast. If only we could monitor them closely amidst of the workload that we have as nurses. Even if you're just monitoring the vital signs, monitor them frequently for the acutely ill patient. You don't have to know everything, but every time you note an abnormality, escalate the care of that patient. By just systematically ensuring that you kind of communicate effectively when your patient is not improving or when your patient is deteriorating, you could just save a life and avoid the mortality statistics in our facilities. I encourage all of us, every time your patient is acutely deteriorating, look at their airway parameters, look at their breathing parameters, look at their circulation parameters, their disability parameters, including the level of consciousness and their glucose levels. Expose them to understand what it is that is causing the acute deterioration. Escalate that care. You will just save a life. Thank you so much for being on the forum and for being the best participants we could have for the evening. Spread the word and save lives. Back to you, Moses. Thank you.
Okay, thank you very much, Madam Faith Silla, for your smoothly learning of the sessions and the discussions. Actually, we had a good time of sharing together. We have seen how loved we are. We have seen very transformative, educative, and skillful presentations and guidance. So thank you, Marco James, together with Duma Joshua, for your skillful and knowledgeable. You have real satisfying the heart of the participants, because you have tried your level best to respond almost like all questions that have been posed by the participants. So also thank you all the participants who joined today. Actually, we have experienced how you feel and how you miss some of the issues concerning with this such good presentations, and probably we have tried our level best to give something that is more better in case of preparations, as we have this closing up note and presentation. So as closing up, because of time, I will just go slightly to some of the announcement together with some of the reminding, because some of us, we joined late. So as we say that today we had participants from multidisciplinary approaches. So we had nurses and midwives. Also we had medical doctors who joined together with us for listening and even having this chance of knowledge sharing. So thank you all for the participating. But almost I said, even for those who are looking for CPD points, who joined together here and they did the registration. Remember, at the end of these sessions, we are going to share with you within your registered email, we are going to share the attendance. So the attendance will verify that you have attended. So typically you can download the attendance and then send to the respective CPD coordinator around your place, and then it will give you a CPD point direct as a recommendation from Mofate, basing on the TNMC guidelines, as we have been said from the last sessions. The other issue, looking ahead, I'm excited to announce our next session on continuing professional development CPD itself. So this one has been scheduled on 25 January 2025. To support the registration system, each participant will register with a fee of Tanzania shillings 1,000, and the registration link will be shared soon. Why? Because we want to cover all issues concerning on how you can get CPDs, CPD itself, but also the CPD points. So all the ways that we are going throughout the year as Mofate, we are going to share with you everything concerning with. But there are some nurses and midwives are lacking knowledge on how to get the CPD, especially online. So we are going to share this as one of the important sessions. And also, we also invite all healthcare professionals, including you nurses and midwives, especially to continue registering and submitting your innovations as we prepare ourselves for Mofate Scientific Conference that will be held in November 2025. So we think on this journey, your contribution will be based on how you register yourself through the system as we are sharing, but almost even the submitting your innovations, based on the environments, based on the areas that we post to you through different posters that are going on. But lastly, I'm thrilled to inform you that the Mofate team and ambassadors will soon embark on innovation ventures and capacity building visitings to various hospitals, training institutions, and healthcare settings. So let us continue this journey, join this journey for growth and the collaborations and the innovations. So we're going to start soon. So we want to plant the spirit of innovations for our own nurses and midwives. So we are looking your support and the cooperations until we finish up our activities. So last thing to say, here we have two issues from the participants. One, they want a session concerning with the electrolyte imbalances. So to know all concerning with hypokalemia, hyperkalemia, and the other electrolytes, because these are the very important. We're just thinking ourselves if the patient is having hypokalemia or hyperkalemia, they end up with a lot of complications that typically make them even to lose their life at all. So this is one of the important area. And me as a president, together with my team, we think that we are going to schedule this session as one of the important area that we have to cover as we nurses and midwives. So you presenters just get prepared, because this is also the same area that you critical care specialists, you have direct role of making the nurses to understand and to go with the innovations in this area. But the other area that you are interested on it is all about ECG. Some of you post that you need the sessions concerning with the ECG itself, especially in terms of interpretation. So I would like to promise that we are going to have these sessions so that we can know how even to read the ECG. So Mr. Duma, because he's here, he will take us through the ECG again and how do we measure just in terms of practice or skills in general, but also how to interpret, how to read and interpret itself. So I think this session will be clear, defining the demarcations of all issues concerning with the ECG. But lastly, you know that we did these basic issues today, but we have the chance from the different health settings where we are. We can join the short course that have been designed by Bogando Medical Center through the coordinator, Marco James, who was presenting today, and also Mr. Joshua Duma. So the short course on critical care have been shared through the Mofate Forum. So we are going to continue share the announcement so that if you have time, and also you can convince your settings to go and to have the 6 months of the short course studies. So you will learn all issues concerning with what they have presenting here, but almost the addition of the other issue that they didn't cover here. So I think that is the opportunity that they have on their hands. So I think by saying this, I'm just said everything. So the notes and the materials concerning with today's presentations, as we said, will be shared to the website, and the link will be shared everywhere. Will be shared to your registered email, but also will be shared to Mofate Forum. Yes, so that everyone can take it and just use it as a reference. So thank you once again. Thank you very much. And I think if there's no special, we can even end up here and close our session today. I don't know if there is something in the burning that needs more clarification.
Thank you so much. Thank you.
Okay. Thank you very much.
Thank you. Thanks for the forum, and we are ready for another series of critical care nursing and midwifery. Thanks very much.
Okay. Thank you very much. So within there, we have attached the link for WhatsApp joining. So if you are not into our forums, you can join the forum so that you can get be more updated for everything that are going on through there. So just click the link and just go direct. So thank you very much, Madam Faith. Can I wish you a nice night and greet all peoples from Kenya? Okay. So Malcolm James, thank you very much. Mr. Duma Joshua, thank you very much. You have to continue preparing yourselves because we are going now to have the continuous sessions. That will be very nice for the nurses and the mediums as they ask you. Okay. So nice night to all.